Good afternoon, everyone, and welcome to the Henry Schein Dental Academy webinar series. My name is Adam, and I'll be your moderator. Dr. Francisco Eraso is our speaker, as he will review treatment benefits and considerations of adding CBCT to an orthodontic practice. Dr. Eraso is an orthodontist, as well as oral and maxillofacial radiologist. At any point during today's webinar, if you have questions, please type them into the Q&A section of your control panel, and we'll answer them live at the end. Henry Schein is not offering CE credit for viewing or attending this presentation live or on demand, and this webinar is sponsored by Cable Imaging and ICAP. With that, I would like to welcome Dr. Eraso.
Hi, my name is Francisco Eraso, and this is my presentation about should I add a CBCT to my orthodontic practice. Very relative to my specialty, I'm an orthodontist and an oral and maxillofacial radiologist. And that's the question that I heard all the time. And a lot of people ask me, hey, which machine should I buy? Or why should I have a CBCT in my practice? And it's a question that they always ask me. And when they ask me to give this presentation, I feel very comfortable talking to you about it. And this is not for me to talk about the way that I practice orthodontics or the way that I do radiology. This is a conversation, okay? And I think you will enjoy the revolution that I enjoyed in 2002. Being already like 18 years with a Convene in my offices, and we opened a company called Beam Readers, 2008. And Beam Readers is a company, and this is also a disclaimer. Beam Readers, I'm one of the two founder radiologists, and Beam Readers is a company that interpret your Convene CT data or information and create radiology reports for the benefit of your treatment plans and your diagnosis. And so we created this company in 2008. I always tell the same story. We started with 200 cases the first year. This year, last year, even with the pandemic, we have almost 100,000 cases. In 2019, we definitely had 100,000 cases. And we are growing like crazy. We are 50 radiologists plus. And we are helping people that have Convene. Before, not everybody has Convene. Few specialists and few dental practitioners have Convene. Now everybody has Convene. And I hope you, again, have the opportunity to buy a Convene in your practice. A lot of people ask me the price. The price is very high. If you think about many things, I'm thinking about having a Ferrari or having a Porsche parked in my office, and it's like with the difference is that Ferrari is giving me money every day. The difference that if I had a Ferrari in my parking lot, I will spend money on it, and every day I got to put extra gas and everything. So welcome. Thank you for your time and being here today. I don't know how many people we have, but I heard that there was almost 180 people registered. And thank you for being here today. The orthodontics area of influence is the facial, the skeletal, and the dental structures. So we have to have the ability to see these structures three-dimensionally. And we always have pictures, we always have two-dimensional x-rays, but we never have the opportunity to see everything in 3D. So the idea for many people that the conventional orthodontic records can provide all of the information that we need is very naive, in my opinion. This was my first orthodontic case in my office. We take, and we still take in now digital photographs, digital panoramics and lateral cephs. We trace the x-rays, and still tomorrow I'm going to teach Indiana University residents, and we're going to say bye to this year residents, and they always take the same records, and they say, should I take a Convene? It's like, for my cases, please, let's go ahead and take a Convene in all of the cases. And the reason is very simple. You have to subtract, you have to segment, you have to squeeze as much information as you can have with the diagnostic data. So when somebody asks me, I'm going to give you too much radiation to my patient? If you are going to produce panoramic pictures or lateral set pictures of the 3D data, yes, definitely, you are overexposing the patient. But when you subtract and squeeze as much information as you have from the DICOM and from the digital pictures, I think you're going to have information that is going to be extremely useful for your diagnosis and treatment plan, especially in orthodontics. Okay, of course, implants, of course, TMJ, a lot of the airways and a lot of stuff. But in orthodontics, we have the ability to manipulate a lot of stuff from early age in our patients to all patients. Have the ability to provide many, many options for treatment and many techniques and stuff like that, different than implants. You place one implant, different brand. But in orthodontics, we have the ability to do a lot of stuff. So you better have information that is going to be useful for your diagnosis and treatment plan. So I evolved from the images that I did in my school, and I do digital, everything is digital images, digital photographs, CBCT. I always take CBCT in my patients. I don't have an option. So I don't have a panel on the set 2D, or I don't have a machine that provides me that possibility. So I always take a combi for all of my records. And of course, I use intraoral scans since 2015 to today. I have an iTero, I have a CBCT, an iCat. I have, this is my second iCat. I say this is my second Ferrari that I parked in my office. I don't remember the price. I'm not going to go into the pricing, but I have that technology in my office all the time, lasers, all of the things. But digital imaging, I'm obsessed with taking good diagnostic information. So when I say squeezing all of the information, we orthodontists are used to spend time doing diagnosis and treatment plan. And in my records, or for my records, I use different softwares, by the way, and sometimes I send the information for bin readers to do something that is called imaging portfolio. And the imaging portfolio is no more than segment all the anatomical structures in different views. The first view that I have from my imaging portfolio is everything together: airways, photographs, a good and familiar picture, which is the panoramic, lateral ceph and PA, and a TMJ. This is a summary. If I want to show this to a patient, I can summarize all of the information in this stage. Then, of course, I have my photographs, and then I start to explore different views. In the panoramic view, from the cone beam, I'm going to see everything in one picture, with the difference that I'm not going to have any distortion or any ghost images or any superimposition. The images that I have from the TMJ are perfect. They are going to correlate with the occlusion. Of course, in this case, you have impactions. So this is going to give me a good view, like a good panel, but with the difference that this is a beautiful panel, okay? And then I'm going to have pictures for the airways. Now, when I have pictures of the airways, I have to quantify the information that I have. And there is two types of information that I have from the CBCT in orthodontics. One is the volume, the airway volume, and the other one is the most constricted area of the airways. The most diagnostical useful information that I use is the most constricted area, that is going to be in millimeters squared. And the volumetric area is very difficult to quantify because it depends on where I'm going to segment or where I'm going to select the landmarks to produce this volumetric data. So the most useful information for diagnosis is the most constricted area that is going to be produced in millimeters squared. Then I have, because I'm exploring, remember, I'm squeezing all of the information for the airways, I'm going to have a coronal view, and in this case, I'm going to have a picture of the adenoids and the tonsillar area. because this information is going to impact the way that I'm going to work multidisciplinary with other people. It's going to work with my diagnosis for the airway. So I always put pictures that are going to influence my diagnosis and treatment plan. One information that I have and that I think is important is the TMJ. The TMJ, I'm going to check the morphology of the temporomandibular joint as well as the position. In this case, complicated like this case, look at in the right TMJ, which is the one in the top, look at the position. It's most posteriorly positioned. The condyle is posteriorly positioned in the glenoid fossa. This is the glenoid fossa right here. This is the articular eminence. This is the external auditory meatus. And you see that the right TMJ is positioned posterior. Then the left TMJ is more concentrically positioned. Both TMJs have good morphology. There is no degeneration or early changes in condylar vertical dimension, but the position of the condyle is something that caught my attention. And the reason for that is if you are going to change the occlusion, you are going to change the position of the TMJ and it's going to produce different results. So it's extremely important that now that I'm subtracting all of the information from the CBCT, I make sense of all of the information that I get. Once I have the information from the airways and the TMJ, I'm going to the dentition. And to the dentition, I'm going to see the relationship of the right canine and the left canine with the adjacent teeth and the adjacent structures, okay? Is going to be any influence or any resorption or displacement because I'm going to see if I'm going to do extractions or not. It's going to be presence or absence of pathology. Here there is a well-defined corticated lucency that goes around the CJ of tooth number 11. That may be important if we're going to make decisions about extracting a teeth or non-extracting a teeth and bringing those canines down. Again, we're not talking about orthodontics or the way that I do it, but it's just information that I have. The position of the canines is those canines are buccal or lingual, are producing resorption or displacement of the adjacent roots. That information is extremely important. How if this indeed is not pathology, okay? This lucency that is here surrounded tooth number 11 is not pathology. How I'm going to access that tooth and bring that tooth into the arch, okay? So it's no way that I can do it with a conventional panoramic radiograph. A lot of people have done it for years and I admire them. I'm used to see everything in 3D and I think it's easier to work when I have all of the information that I have three-dimensionally. So as you can see, the imaging portfolio will give me the ability to segment all of the structures, put a plan together, think about building your practice, okay? Put in different pictures and this is what I want to have, this is what I have, this is what I want to put and what I want to do. And then I do my treatment plan and then I execute, okay? So if somebody asks me that I'm radiating my patients too much with the CBCT, I would say yes, but look at all of the information that I have, okay? So radiation dose is not an issue for me because I really do a big workout. And in this case, I'm not showing the tracings and stuff like that I usually do with other cases that I'm going to show you at the end of the presentation. So it's extremely important that you understand that the best results start with an adequate and complete diagnosis. Everything that we have to do, we orthodontists, we spend the time to do our diagnosis, select our treatment plans, and execute the best way. That is why we are orthodontists. That is when we went to school 2-3 years more and providing our patients something different than other people are providing in our community. So three-dimensional imaging, Cone-Beam CT, ICAT. If somebody asks me what machine you are recommending, I'm 100% ICAT. And the reason is this, okay? Why ICAT is the best machine? First of all, is the company that produced, in my opinion, more Cone-Beam CTs over the years. Most of the clinicians, some of the finest clinicians have ICAT. So I have ICAT, I have 2 ICATs and never give me a problem. The first one that I sold is because I changed it for a new one, not because it failed me. Okay, I never failed, never called technician. The sensors were working perfect, and that is my recommendation. If I have to do a recommendation of a product. Then when we have this information, we're going to have a diagnostic key. The airways, how I work in my orthodont. Again, I'm not trying to say the way things that I do in my practice, but the airways, the TMJ, and the dentition are the diagnostic key for my treatment plans. Okay, I always have to see and analyze this structure and the surrounding structures to find a diagnostic key for my treatment plans. The airways I usually go together with the sinuses, the maxillary sinus and paranasal sinuses. The TMJ always goes together with the occlusion, and the dentition always goes together with the alveolar bone, and of course the occlusion and the dentition and the impactions, etc., etc. And the dentition is extremely important that goes together with the alveolar bone because we are moving teeth to the alveolar bone. So we need to know if we have bone to move teeth, if we have, if we're going to do expansion, what is the effect on the surrounding cortical outline. And today we have technology, and we're introducing technology to use CBCT to be used in our aligners, for example. So now we are going to treatment plan. Before, remember, we said, okay, we're going to do indirect bonding treatment plan, and we only have the models, and we position the brackets in the models, and then we deliver those indirect bonding trays. Today, you have the ability to introduce the CBCT in that treatment plan for the indirect bonding. Today, again, we have the ability to introduce the CBCT into the diagnosis and treatment plan of the liners. Why is important that? Because sometimes we are moving teeth in places that we don't have bone, or sometimes we're doing some movements and we are taking the teeth out of the bone. I'm not saying that that happens all the time, but one out of like 1,000 people, if we take radiographs and we do follow-ups and compare before and after, we're going to figure out that maybe sometimes we don't have enough bone to move teeth. Sometimes people, okay, and this has happened many times, a lot of people ask me what happened here, why this molar is not moving. Pneumatization of maxillary sinuses, okay? The floor of the maxillary sinus pneumatized into the space between the first molar and the premolars, and you want to move the molar mesially, for example. And there's no way that you can move that molar mesially. And suddenly you see tipping of that crown, and you cannot correct that. And you take the x-rays and something happened to the x-rays. And the reason is the pneumatization of maxillary sinus is literally moving the roots through the air of the maxillary sinus. And it's very difficult, and it's going to take time. So three-dimensional information is going to give you the ability to create options. Once we have the diagnostic key, I create a priority list. And I do that all the time. The thing is, I do it with more confidence today than I used to do it when I was a resident, for example, in 2005. The priority list that I create is based on the diagnostic data that I have. Should I do sagittal first? Should I take into account vertical dimension? Should I do expansion first? Should I only align teeth? Okay, so which one is going to be first? Which one is going to be my priority? And it's extremely important that you have all of the diagnostic information in order for you to make diagnostic and treatment planning decisions. So convene is extremely important in that area. So I strongly recommend you to consider adding CBCT into your practice. So now let me show you some cases, okay? And with our cases, I want you to visualize the end before we start. Remember, when we have aligners, well, a lot of people, mostly 100% of the people that attend today are using aligners. So with aligners, we visualize the end before we start. With the CBCT and all of your diagnostic data, including the photographs and the intraoral scans, we are going to literally visualize the end before we start. So taking into account the diagnostic key, airways, TMJ, and dentition, I'm going to show you how CBCT influenced my practice in my treatment decisions. So the first case that I'm going to show you is about airways, okay? And the airways is something that a lot of people have been talking about, how can we influence the airways? How can these movements produce these results? How we can do expansion, how we can do this, but how that expansion influence at the end the airway spaces. So first case, sometimes I use the carrier motion appliance. Actually, no, sometimes no. I'm 100% emotion appliance. I haven't used Herbs or Mara in a long time, maybe 4 or 5 years. And I'm always curious about, the video that Luis Carrier shows in all of the meetings and talks about how the mandible rotates, how they influence the airways, how influence the position of the TMJ, and how, of course, create the space and distalize some of the posterior segment to correct the patient into class 1. That mechanism is very clear, the class 2 correction mechanism used by the motion appliance. By using that mechanism, this article explains, or kind of like makes sense, that once the mandible rotates forward, the tongue will move also forward, creating more space for the tongue, okay? They have, I don't remember how many cases they have, but they also measure the most constricted area and the volumetric data. Remember at the beginning of the presentation, we talked about the volume and the most constricted area. And the minimum constricted area have a significant increase from 171 millimeters squared plus or minus 56 millimeters, with a percentage of increase of 23 millimeters, 23.48% increase of the airway spaces. When you see that information, you say, oh, wow, this makes sense. They explain the mechanism, they explain all the information, but 23% increase of the airway spaces for me is nothing, okay? If I'm not going to do treatments to increase 23% of the airway spaces. In my experience, I increase way more the airway spaces when I do, for example, motion, when I do expansion, when I do a lot of things. The only difference is I measure everything and I compare. So you have to create a baseline, okay? You have to create the diagnosis. You have to measure the airways, either if it's something that is going to be constricted or if it's normal, within the normal limits for the patient age, and to see whatever mechanics we use, how much we increase the airway spaces. So let me show you one case, pretty cool case, easy case, nothing major. I use these values for the airway spaces, okay? When the minimal cross-sectional area is less than 52 millimeters squared, there is a high probability of obstructive sleep apnea. When it's between 52 and 100, it's an intermediate or medium obstructive probability or OSA probability. And when it's more than 110 to 150, is low probability of OSA. However, the same article also explained that the airway spaces increase in dimension approximately 10 millimeters squared per year. So if it's a patient of 12 years old, they should have 120 millimeters squared minimum. So that's the minimum cross-section area for the patient age, and different ages, the same times 10, okay? So I see children and I see adults. This is a very young adult that came to the practice to correct a unilateral. The patient is not concerned about that, but the patient feels like she is not biting okay. However, when we do the clinical examination, we see an asymmetric class 2 malocclusion, right class 2, left class 1, okay? Midline discrepancy, crowding top and bottom. We use the motion appliance. We use Propel to create the faster movements in the posterior segment, the first segment of the treatment. With the use of elastics, we correct the first segment in 3 months. And now the segments are class 1 in the right side and super class 1 in the left side. So I overcorrect. I create the spaces that I always create, okay? When I use that, and in 6 months total treatment using aligners, we finish the case, okay? So like, okay, that case is nice. That case finished really nice with aligners and motion and the use of Propel. However, what is the impact of the surrounding structures? Clinically, we can do that. We can do this all day long, okay? In our practices, a lot of people are obsessed about how fast I finish the treatment, and other people are how detailed I do the case, how beautiful I post my my picture in social media, or how nice I present these results to the patient. All of the above. However, in the presentations that I have to my patient, I literally demonstrate and quantify how much airway space and how much changes you produce in the airway spaces. First of all, the stability of the TMJ. Remember, this is the external auditory meatus, beautifully rendered by a cross-section of the TMJ using the CBCT. Then I measure the articular spaces. The condyle is positioned concentrically and is ending concentrically positioned, so it's not any discrepancy in the condylar position. Sometimes when we correct class 2, the condyle have the tendency to move forward or anteriorly. And when the patient finishes the treatment, the patient had the tendency to position again to the concentric position, and then the patient goes back into class 2 and is the typical relapse. So the best occlusion and the best condylar position is the best retainer, okay? But the airways increase almost 100%, 50%, from 279 millimeters square in the beginning of the treatment to 450 millimeters square, almost 50% increase of the airway spaces. So we have to diagnose, we have to analyze, we have to prove, we have to quantify, and all of those things, you're going to be able to do it with a cone beam CT in your practice, okay? Then you have the TMJ, okay? With the TMJ, without going into details, we have clinical signs and symptoms. With the clicking and locking, you're going to have a radiographic signs such as sclerosis and flattening. Sometimes in the TMJ, we see erosion. Erosion means degeneration. We're decreasing the articular spaces, so narrowing of the articular spaces. So this is the active part of the degenerative joint disease. And then you have the more stable or the secondary osseous remodeling in the degeneration, which is the osteophyte formation of subchondral bone cyst. When we talk about the disc, we have clicking and popping is going to be articular disc displacement with reduction, and non-reduction usually occurs in the non-active, on the active DJD. Then for the bone, for the remodeling, with all of these signs are symptoms of osseous remodeling. Sometimes can be functional, sometimes can be remodeling of growing, normal remodeling. But then when we see those signs, we have DJD. And then if those changes occur, okay, the growth is being interrupted in remodeling and is going to be decreased when you have DJD, especially in young age. So all of this, knowing that I'm telling you this story really fast, okay, you have to be able to see that in your x-rays. In a panoramic x-ray, is no way that you can diagnose DJD from osseous remodeling, condylar position, because sometimes you use the bite fork, and there's no way that you have a good diagnosis of the TMJ. If you don't use CBCT, is no way that you're going to be directed in the right direction with your diagnostic information. So it's extremely important that you use the right information. And the only one that can give you that is CBCT, okay? So let me show you a case, okay? Since I beautifully use my technology, and before I show you the case, this is the typical map that we have for the normal TMJ remodeling. You see sclerosis, you see flattening. Then you have changes in the anterior-posterior dimension, and this is called regressive remodeling because there is no changes in the vertical dimension. Then you start to see changes in the vertical dimension with erosion, non-corticated, which is an active DJD, and corticated, this is a non-active DJD, and then you have the flattening, the osteophyte formation and the subchondral bone cysts. So you really have to see that. And then you have to determine the condylar position. A stability of the TMJ, a stability of a good occlusion is going to be a stable cases for life. If you don't have a stable occlusion, it's not going to be stable in the TMJ, and eventually the patient is going to have relapse. And stability in the occlusion and the condylar position is going to give you, that is going to be your perfect retainer. And the only way that you're going to see that is with a CBCT information. Let me show you now the case. So this is Alejandro. Alejandro is a 12-year-old patient, deep bite, bilateral molar and canine class 2. Very difficult case to correct with different modalities. I try to be as simplistic as I can. I'm going to use a short motion appliance in the right side, conventional length in the left side. This is the picture of the Alejandro before the treatment, okay? Before I decide to do motion. Look at the typical position of the TMJ, of the condyle in class 2. Deep, full cast class 2, okay? And look at the position of the TMJ. No issues in the airways, okay? So I'm not necessarily have to see issues in the airways to say, okay, this is an airway problem, okay? But ideally, it would be nice if I rotate the mandible forward and reposition and position the occlusion in the right place. I want to see more airway space because more oxygen, better growth, okay? More oxygen to the brain, better growth. So then you have the motion, 3 months, excellent compliance. This is the phase 1 before the refinement. And look at the correction of the class 1. Look at the correction of the class 1. I have few spaces that I have to correct. By the way, the patient came 2 days ago for the last 2 aligners, and the case is done. But look at the beauty of the airways. Look at the beauty of the correction of the vertical damage of the deep bite without getting into complicated mechanics. Look at how well the soft palate is rested in the tongue, and look at how much the airways increase from 315 from the initial study. Look at how the mandible rotate down and forward. Look at how much now we have the airway spaces, 526 millimeters squared. So I'm not bragging about how much airways I create or how much beautiful the airways are presented, but 23%, if I'm talking about 23% of the article, and say, yeah, that's nice, but I think we can get better results. But we have to measure those results. And now look at the position of the condyle. The condyle is positioned posteriorly. This is the glenoid fossa, articular and external auditory meatus, articular eminence. The condyle is positioned posteriorly. Look at how nice and well centered is that condyle. The main question that a lot of people ask me is, how much radiation should I give to the patient with this kind of information, this kind of cases, okay? I use 0.3 millimeter voxel size and 4.8 seconds. With that information, I think I have enough information. If from that information, I see some degeneration, I see some erosion or something, I think the following exam, I take a higher radiation, maybe the same voxel size, but more like 8.9 or even more time in the radiation, so I can see more detail in the cortical line to see progress or regeneration of the TMJ. So that is the question, because these condyles are not beautifully corticated, but it's not because the patient presented pathology, it's because I didn't give the patient that much radiation because I didn't need it, okay? So again, we did airways, we did TMJ. The case that I'm going to present to you now is talks about dentition, okay? And in the dentition, again, I use, because I have to subtract all of the information from my patients, I use the COMBIN, and I use the diagnostic imaging portfolio from Beam Readers, which is going to summarize in everything. All of the x-rays that I take has radiology reports because I'm a radiologist. However, you don't have to do radiology reports in all of your cases. Let me say it better. You should understand what you are getting, and you should have information in your clinic charts. However, if you have some questions about things that you don't understand in the findings or in the CBCT, then we can help you doing a radiology report. So again, imaging portfolio, summary of all of the information of the case. This case is very interesting, okay? Class 2, but look at how much flaring, how much increase of the axial inclination of the mandibular and the maxilla incisors are happening for the maxilla and the mandible. Constriction of the airway spaces, and definitely 13.5 millimeters square is very constricted for a 12-year-old patient. And So when we take the pictures on the sagittal, sometimes I measure the dimension of the soft palate. More than 35 millimeters length of the soft palate is considered abnormal, and it's a contributor factor for obstructive sleep apnea. We don't diagnose obstructive sleep apnea, but we recognize factors that produce obstruction in the airway spaces. Then you have the probability values. 13.5 millimeters squared is definitely very constricted, and we do cephalometric tracings, and we do radiology reports. Okay, the cephalometric tracings that I do with Anatomash. The Anatomash is a software that comes with a CBCT machine. However, you have to buy certain segments. I bought the segment for the cephalometric traces, and the Anatomash I used to do anatom models, and I'm going to show you that. The anatom models are going to segment the dentition, so sometimes are going to be useful for your diagnosis. I'm going to show you that. In the radiology report, I have to go sequentially of all of through the anatomy. And based on the sequential findings on the anatomy, let me see if I can do that. Here you have the CBCT, and then you have to look airways and maxillary sinuses and paranasal sinuses. Okay, then you have to go TMJs. You have to look for TMJs. You go from one side to another. Here, as you see the TMJ, and you're going to describe the findings here and here. Okay, very quick. I'm sorry, I'm giving you a quick tour of radiology reports. Then in my gallery, I have very useful information as far as panoramics, as far as models. Okay.
Hey, Dr. Eraso, I can't see what you're showing right now.
Oh, okay. I'm sorry. Yeah, I was talking here. Let me stop share and let me share again, okay?
Yep.
At least you're
there you
awake.
go.
At least you're awake, my friend. Okay, so here in the cone beam, you're going to see the NPRs, which is the axials, the sagittals and coronals. And here you can explore the maxillary sinuses and paranasal sinuses. And here the sinuses, here the paranasal sinuses. Then and the airways, of course, and you measure that, and I'm going to show you in the report. Then you're going to be able to go side to side to look at the TMJs. Then you're going to go into the panoramic. And you're going to have models, you're going to have familiar pictures. So I reconstruct all of that information before I do the description of the findings. So let me go ahead and stop sharing, and I'll show you the report, okay? 1 second. Okay. Are you able to see the radiology report being readers slide?
Yep, all good. Just make it full screen.
Okay, perfect. So then I have the radiology report, okay? And remember, I do my imaging portfolio, my radiology report. In my radiology report, I make all of the description and all the findings with the observations and impressions. And in the pictures, in the second and the third picture, I illustrate my diagnostic findings, the TMJ, the models, and then I describe the length of the findings for the airways, look at how much hypertrophy of the tonsils the patient is developed and is producing that kind of obstruction. And then you produce images, okay? The beauty of these images, okay, for this case, is that then I say, okay, I think Santiago is having some airway issues, and I concentrate too much into that, okay? And look at, yes, of course, we're going to refer that to the ENT. The ENT is going to produce some of the changes. We are going to quantify that, okay? And look at the changes after, okay? This is before, and this is after. And look at the superimposition right here, okay? This is the superimposition. The green is the after. The more dark is the before. So you have a little bit adenoid tissue, and you have, of course, a huge condylar hypertrophy. Then with the Anatomash, we can do some segmentation of the teeth and TMJ and hard palate, okay? And we can do treatment planning, okay? And then you can segment the teeth, you can put as many colors as you want, and then you can create treatment plans, okay? And for example, in this case, we can move teeth, and then we can move the teeth into class 1 and into class 1. The problem here is this, okay? In this case, and this open the eyes for this case. Look at how much flaring of the upper and the lower incisors. Very difficult to correct that class 2 in this case without correcting the habit, okay? The reason why the patient has those teeth so flared is because she was trying to breathe. Remember, the airway spaces were 13 millimeters square, and that is very constricted for anybody, especially for a 13-year-old, which is almost 6 feet tall, okay? She was not sleeping well, and of course, she was trying to breathe by positioning the tongue forward. Now, in our decisions for our treatment, you have to take into consideration this flare, not necessarily to extract it or extract it, whatever you want to do, but those are the decisions that you are going to consider in the class 2 correction. And that is the beauty for the CBCT. Allow you to do the segmentations, allow you to do treatment planning, allow you to do a lot of stuff. As you can see, I'm showing you a lot of stuff, a lot of treatment decisions that I have done with my cases. And this is one of the things that opened my eyes. It's like, oh my gosh, I'm trying to correct the class 2. I was very successful because I used the technique very well, but the patient relapsed immediately. And the reason was because the tongue was still pushing forward and not allowing me to correct this fast enough or stable enough. So the last case that I'm going to show you is, again, a report that I have, a patient that I have, a brother that have not only adenoid but tonsillar hypertrophy, very early mixed dentition, class 2 relationship, okay? And again, you're going to segment and you're going to diagnose, you're going to go over the whole study, and you're going to go before and after, look at the beauty of the interaction with the ENT. So sometimes this happened to me, okay? All the time. And I send the patient for an ENT, and the ENT send the patient back and say, don't worry, those will shrink, okay? I don't do anything. And I said, no. I want treatment. I want you to do adenoidectomies and tonsillectomies when necessary. So in my reports, I mentioned something. If possible, adenotonsillectomies and possible orthodontic and orthopedic AP manipulation should help to increase total volume of airways, thus reducing the overall risk of OSA. Okay, that statement is huge. And it happens to me that I wrote that in a lot of my orthodontic referrals, that send me cases for interpretation, and the interaction from them with the ENT is awesome. Okay, so because they appreciate that we explore that area, they appreciate the plan that we sometimes do, maybe expansion in combination with tonsillectomies, in combination with the correction of the sagittal relationship and improving the airway spaces. So CBCT is that tool for conversation, not only with the patients when we create beautiful pictures like these ones, but the possibility to have interactions with other professionals. So look at the superimpositions before and after. So the beauty, and we are master of that. We love to superimpose, we love to compare before and after, and these are pictures that speak by themselves. And these pictures are showing how effective we are with diagnosis. And now we have to do a treatment plan. There is no space for the incisors. The central incisors are very big. And so the man is questioning what happened with those incisors. So very simple, phase 1, really kind of like a monitoring how everything is erupting. And so we explained it to the parents, okay, the incisors are too big, maybe we have to extract the lateral baby teeth. And Then we create that video and explain to the parents that once we do that, I think the teeth are going to come into place. And then maybe we can start treatment or do something. And the possibility of erupting of the lateral incisors at the lateral incisors at the same time is very difficult. And so in this case, I decided to do some expansion, create some space between the centrals and lateral incisors, also creating, and that was one of the decisions in conjunction with the adenotonsillectomies. And then you have that. You have, this is the way that the result after the extractions of the baby teeth. And then this is the follow-up X-ray. And then you have some renderings of the possibility of, I'm sorry, 1 second. The possibility of expansion, okay? So I think the renderings of the expansion are somewhere here. I think somewhere here it was like when I move the teeth and create the expansion, I create some space. So I think I have enough time for you to ask me some questions and maybe spend time coaching. This is the expansion, I'm sorry. So then we do the expansion, create the space for the lateral incisors and create the space for all of the other incisors to come down. Phase 1, easy phase 1, extraction 2x6, and a very simple case, but we interact with the clinicians outside with the ENT. We explain very well to the patient's parents, so the patient parents understand what we are doing, and we document the case very well. So thank you very much. I am, it's a good time for some questions, and I open the floor for questionings and interaction.
Awesome, thank you. Well, we've got about 10 minutes left. We've got a couple questions queued up here, but if anyone has additional questions, feel free to drop them in the Q&A or chat, and we'll get to them as we can. The first question here is, if you want to see a pano mid-treatment, would you take a new CBCT?
It's a very good question. Okay, so my expectation is that you are not going to have 2 machines. Okay, so I strongly recommend that you take that 2D machine out of the office because of the space and have a combi. Okay, so the follow-up panel is something that is necessary for many reasons. Okay, and with that you're going to be able to see the possibility of ripples and everything. Okay, and with the combi you are going to be able to collimate. We can use the terms, it's easy to understand. We can collimate the area of interest. So we are not going to take all of these areas, so you are going to take only this area, okay? So you are going to reduce the radiation with the biggest difference that you're not going to have the typical projection angle that you have with the lateral, with the panoramic X-ray. I did my thesis in panoramic when we were trying to explain the physics and the mechanism of the conventional panoramic with the new machines, okay? So the projection angle at the level of the premolars was 115 degrees, okay? So when you do this, in order for you to have a beautiful and nicely rendered roots in the premolar area, it has to be 90 degrees. The X-ray has to go 90 degrees. If not, you are going to have distortion. The X-ray beam at the level of the premolars enter 115 degrees, okay? Producing overlapping and producing a misconception area, especially in the premolar area. So that information that you have in the panoramic is not true. And you're going to have some mistakes sometimes. So I strongly recommend to take a combine CT for your ripples because you're going to have more accurate information. Collimate that information, use 4.8 seconds, 0.3 millimeter voxel size, and the radiation dose is not going to be a concern because you're going to have accurate information. You're going to take that information to the patient's mouth, and you are going to have, you're going to finish the case with right information. So that is my take on the midterm panoramic.
All right, and the only other question I'm seeing so far is, what are the landmarks you use for measuring the airway volume?
Yeah, definitely. It's a good question. And the landmarks that I use is the palatal plane. You put a point into the airway space and the top of the epiglottis. If you use the same landmarks, you can use that. If you use those landmarks consistently, I think you can take the information, of volumetric information, some kind of meaningful information. But the most accurate information is the most constricted area of the airway space. So you always go from the palatal plane all the way to the epiglottis, and you find, the computer will find automatically the most constricted area in between those areas. So usually is posterior to the soft palate and tongue. And that is supposed to be the most constricted area. That is where the tonsils reside, and you find that information very accurately.
Great. Well, I'm not seeing any other questions, so oh, maybe one just came in real quick here. Can you wait for the tonsils and/or adenoids to shrink on their own?
It's a very good question. No. I will answer the other way. The answer is no, and I'm not that patient. Okay, and if I see my kid suffering and not sleeping, and if I see my kid gaining weight because he's not sleeping well, and is sleeping at school, and is suffering from attention deficit disorder because is exhausted. So depends of the shrinking of the structures. The adenoids is different. I think the adenoidal tissue have the tendency to shrink. The tonsils, when the tonsils are big, they are going to relapse, and they're going to be increasing in size and decreasing in size forever. Okay, so if it is for you to take the tonsils, I think, and if it's going to influence the volumetric airways, is going to influence the position of the mandible, is going to influence all of those things, growth and development and all of those things. Definitely for the tonsils, I will not wait. For the adenoids, yes, I can wait for them to shrink.
Looks like we had a follow-up to that, just asking, do you expand and wait?
Yeah, but I have to it's a good question, Oscar. And Oscar, I guess is the Dr. Oscar Gomez is the one that is asking the question. And expand and wait. Yeah, definitely. So what I do is I use, not necessarily I use expansion just for correction of the crossbites, but also I use an expansion to expanding the maxillofacial structures. Okay. So when I do expansion in mixed dentition, and I do the expansion, I finish, I create the space for the teeth. Now I have an area that I can monitor. Okay, the centrals and the lateral incisors are completely erupted. I have good dimension. If I extract the first molar, okay, the first premolar is going to come down. Once I have that premolar, I'm going to see if that canine is going to be redirected. Okay, so definitely I will wait, expand and wait until all of the teeth are coming down in the right place. And if they are not, I'm going to continue doing the phase one treatment. If in that year everything is going the right direction, I think, which is most of the time I achieve that, I kind of redirect everything. I wait until the eruption of the second molars, and I finish the treatment with aligners or a very simple orthodontic therapy.
Okay, now I think we're out of questions. So I'll do my wrap-up spiel, but if anyone's got any last minute cues, now is your time. Today's webinar was recorded, so everyone will get a recording sometime in the next week, maybe by the end of this week, we'll see. So keep a lookout for that in your email. If anyone has additional questions about adding CBCT to your orthodontic practice, please feel free to email us at webinars@henryschein.com, and we'll be happy to route your question accordingly. And then lastly, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule.
Yeah.
So
I think I have some information about the webinars, the
yep,
email.
there you go.
This is the information. If you want to ask some questions, specific questions to me, and this is the homepage for Henry Schein webinars. The question that I have for everybody is what are you waiting for? Just please make the right decision. I think Henry Schein has a variety of products, and I think what are you waiting for? I think your life will change dramatically in your office. And one thing that I want to warn you is we as an orthodontist are used to spend time doing diagnosis and treatment plan. At the beginning, you will spend a little more time, but over time, you're going to benefit tremendously, especially now with all of these um, additions for scanners and aligners and indirect bonding, but using CBCT. I think it is the time for you to have it. So I encourage you to explore the technology, go to the meetings, visit your sales reps, and do it. In Bean Readers, we are able to help you. And if you need help with a specific class, and I'm sorry, I'm going to have a little question as far as the little announcement. We have a specific classes if you want to take after you buy your Conbeam. If you want to explore more like anatomy, if you want to understand really the anatomy with the Conbeam, with the 50 radiologists, we have a lot of people that can give you a tutorial for a very small fee. And so glad to help you, and thank you for your time today.
Awesome. I like it. What are you waiting for? Good way to end it. All right. Thank you, Dr. Eraso. Thanks everyone for joining us. Have a great night.